Thank you, Christina, for introducing me, and Pere Joan for inviting me. I hope that I might qualify for honorary Catalan citizenship in due course. It's a pleasure to be here, to be able to discuss a sideline of research in tuberculosis. And my aim is to convince you that it deserves attention. I want to honor the purpose of this conference, to discuss whether we can answer the question which Pere Joan formulated: can we eradicate tuberculosis? So maybe, although the subject was discussed earlier today, maybe just to make it clear the terms of reference, what is eradication? I should emphasize that 90% of people who get infected never develop active disease. They have a latent infection. So one could conclude two things from it. One, that 90% must have very effective host resistance. And if that can work naturally, it is tempting to think, can we use the mechanisms once we understood what is behind it and how does it work therapeutically or preventively to protect the 10% or to treat the 10% who do develop the disease. I should make it quite clear that tuberculosis control, the way it is carried out worldwide, is not aiming to eradicate tuberculosis. It is aiming to control the disease. So it deals with the 10 problems of the 10% of the infected. It is measuring the success by improved mortality and not by reducing the infection. And that eradication is a term which was used when smallpox was eradicated. It does not exist in the world anymore, or in some countries, a polio infection. And that is a long shot, but just to make clear, what is being done in the world is the control of tuberculosis, which tries to reduce the active disease. Just briefly, what I'm aiming to discuss is to recapitulate what are the elements of TB control and how does immunotherapy, which is using immunological factors to improve the control, come into it. What are the clinical targets, what's the history, that there are non-specific agents and specific agents specific for antigens, and finally come back to the question of eradicating tuberculosis. So diagnosis of sputum positive pulmonary TB is straightforward. As far as the patient is concerned, they are identified and treated. The procedure fails completely that by the time when the diagnosis is made, all those in the household or in the community who are susceptible for infection, they would have been infected. So the transmission is not affected at all. And that's a major failure, and that's perhaps the confusion that initially, when enormously successful chemotherapy was introduced, people were optimistic, thinking, oh, this will lead to eradication. And in my opinion, very little effort is being made how to diagnose earlier with the view of preventing transmission, not for helping the patient, because the patient eventually will be diagnosed and treated, but to put the emphasis on early diagnosis. And here to add that the reasons why it is failing are not technical, they are socio-economical. are the attitude of the patients, their willingness to come to see a doctor and the whole system, which I don't have time to discuss. But we have perfectly good diagnostic procedures, but the implementation is blocked by socioeconomic factors. Chemotherapy, again, is failing because of geographical differences, standards between the health services. There are poor countries, there are poor people in rich countries. And then the consequences of poorly implemented chemotherapy are quite dramatic. I will not discuss the BCG vaccine because BCG is failing against a major form of tuberculosis and doesn't prevent latent infection. And I'll concentrate more on the immunotherapy and the prospects of that as an alternative for improving or as an adjunctive to chemotherapy. So what are the clinical targets for immunotherapy? To shorten the chemotherapy. Because it takes 6 months, people default. And when they default, then they relapse, transmit, develop multi-drug resistant strains. So by shortening with some adjunctive immunotherapy, a major improvement would be achieved. In HIV-infected individuals, a prophylactic would be justified because they have a very high rate of risk, very high risk of reactivating. Secondly, because the joint chemotherapy and retroviral therapy has toxic effects, the two treatments don't match. And finally, because developing active TB is very bad for the progression of HIV infection. Robert Koch, already in 1882, thought of immunotherapy. He used a crude extract, tuberculin, and that turned out to be very toxic. He had to leave that behind, but it led to a skin test which is being diagnostically used until now. During the 1920s and 30s, before the discovery of chemotherapy, patients were treated in sanatoria, and there are well-controlled studies showing that giving them cod liver oil as a source of vitamin D and sunshine improves the chemotherapy. So that was adjunctive. Were without and also later on in the 50s with chemotherapy. But in a commentary to one paper in 2003, Peter Barnes wrote that this is still a way for the future and windmills, and we have a promise, but nothing tangible has happened. So the whole field is not in the mainstream of tuberculosis research. The adjunctive dietary supplements are the first category, and it is well known that people with malnutrition are not responding so well, that adding vitamins is beneficial, and some groups in the Ukraine are developing herbal constituents to improve it, and a major meta-analysis of several trials show that yes, indeed, dietary supplements are potentially beneficial. I would like to convince you that host factors are important on how drugs work. There is a need to convince you because people who work on drugs, they think the host is unimportant. They have clear mechanisms how an antibiotic works, and that has nothing to do with the host. But I would like to show that the host, the nature of the host is relevant. And that's easier than convincing you that one can use these host factors as an adjunctive treatment to improve the chemotherapy. That's a much more difficult second task. That's why I gave you 2 question marks. So this is a simple recent paper, 2011, from a very reputable American laboratory, showing that mice that treated with the standard human type of chemotherapy are reducing the infection in the organs less than guinea pigs, and they attribute the difference between the species that these are non-necrotic lesions, these are necrotic. You get differences also according to the immune system. Nude mice do not reduce their bacterial count very well. They remain resistant to treatment, whereas the conventional biopsy mice, after 3 months, reduce their count. So something the T cells are doing in influencing how chemotherapy works. We did some experiments where we looked at the reactivation of tuberculosis. Well, it was really BCG infection, and we applied rifampicin isoniazid immediately in the first 3 weeks, and the animals became sterile and they never relapsed. But if the treatment is delayed, then they do relapse spontaneously. This is shown here. We failed to discover what is the difference in the delayed action, whether because cyclosporin has aggravated the infection and reduced the infection, but that the relapse remained the same. So that remained inconclusive. One conclusion, however, you might find surprising, that this works with BCG, because people normally think that reactivation is is an attribute of virulent tuberculosis. And some people didn't believe that this can be done by BCG. So presumably the genetic elements involved in that are not ESAT6, but some other constituents which are shared with BCG. When people think, how do immunological factors work, there are 2 possible approaches. One, that they kill off the persister bacilli which are left behind by chemotherapy, non-dividing organism. The second approach is that they somehow make the granuloma, where the infection is residing, more penetrable or something like that. There is little direct evidence to support the first mechanism. It is a theoretical assumption rather than something supported by experimental work. So the granuloma factors, the influence on granuloma formation and how it responds to chemotherapy is based on the assumption that TGF-beta1 and IL-10, basically the Th2 cytokines and T regulatory cells, which are at the edge of necrosis and surrounding the fibrous envelope, would prevent the access of the drugs, and that would be improved, and particularly if they are in the necrotic lesions, extracellular bacteria. And a number of other drugs have been used to reverse that state, neutralizing antibodies against the cytokines and inhibitors of TGF-beta1, and more recently activation of Th1 cytokines. So this would fall to the category of non-specific immunotherapeutics. The vaccines, some of the prophylactically used vaccines have also been used therapeutically, and the results are controversial. It worked in some experiments that relapse from an incomplete chemotherapy was prevented when it was combined by chemotherapy, and others did not. Pere Joan reported the successful experiment where rutivaccine liposomes was effective. There are some cytokine, again, non-specific factors which have been used, IL-2, IL-12, prednisolone, with a variety of results, not all of them successfully effective. These are the results of clinical studies where both non-specific and specific factors have been used. My own work for the past about 10 years was on treating with antibodies, which is a controversial subject because people think that tubercle bacilli are intracellular, so how can antibodies reach them? And I'll try to indicate or show that they do reach the infection. They were initially in the convalescent sera. Then that was abandoned when McCann and others showed that it is T cells which protect against tuberculosis. But more recently, it was shown that strains of mice which lack antibodies are more susceptible to TB, develop more severe disease. And several people in different laboratories independently in this period reported that monoclonal antibodies to different antigens after systemic or intranasal inoculation enhance survival, reduce the infection in organs, particularly in lungs. And my work was involved with using an IgA monoclonal antibody. So initially we reported that IgA alone can significantly reduce the infection in the lungs, but only for a short period, 9 days. Later on we supplemented IgA with interferon gamma and showed that the protection lasted longer, 4 weeks. And then ultimately we added antibody to IL-4, expecting that IL-4 is interfering, and that made it even better. So with time, our means of protecting essentially with antibody combined with cytokines or a combined immunotherapy has improved. The mechanisms, well, because it was not diminished after 24 hours, we think something in vivo has happened. That in vitro we could demonstrate inhibition, but opsonization alone does not explain the protection. We then took the model in which we treated the mice with chemotherapy with a regimen from which they relapse, and then use the combined immunotherapy at different periods. And it turned out the time when the combined immunotherapy was used had a great significance. That the best result was here when the relapse was completely blocked, using it at 5 weeks, for 1 week. And it worked much less at when giving it either before or after 5 weeks. This is the relapse of the control group. This is the untreated group, and so it was a very significant reduction. So the mechanisms how IgA immunotherapy can work, and in combination with chemotherapy might prevent the relapse, is that I think the IgA isotype is important because it has a very powerful signaling mechanism for an Fc receptor on infected macrophages. that the antigen specificity is significant. It's an alpha crystalline, ACR, which is expressed by tuberculobacilli when they are latent. That the intranasal delivery was important because it brings antibody to the lungs. Intravenous injection does not. That we have to treat before and after infection, that there is a synergy with interferon gamma and antagonism with IL-4. So the mechanisms might be better demonstrated on the next slide. We think that the antibodies get into the phagosome, they block the phagolysosome fusion, and then they multiply. But if they are coated with antibodies, they might block a molecule called galactin-3, which is overexpressed on the infected phagosome, and that may enable the fusion with lysosomes and can lead to killing. The alternative mechanism is that it involves TNF-alpha mediated apoptosis. We recently produced also a human IgA antibody, and with human antibodies, the receptor for IgA is molecularly defined, CD89, and we showed that this human antibody worked only in mice which carried as the IgA receptor. They were transgenic for CD89, so that proved that it is an Fc receptor mediated protection. For the future, what can be improved? I think there is a great potential in a recent discovery from Cambridge that antibodies bind with very strong affinity with an intracellular cytoplasmic receptor called TRIM21, and that leads to very efficient neutralization of viral particles, and it triggers ubiquitin ligase activity, which leads to the destruction. There is no evidence that this would work with tuberculobacilli, but I think that would deserve further study. The TRIM21 is using a domain which is shared with the IgA binding galactin-3. So these are all potentials for future research. Another blue sky prospect for the future is a report where instead of antibodies, people have cloned successfully the T-cell receptor and were able to use basically what you can call gene therapy with a T-cell receptor to demonstrate specificity for tuberculosis. They used the gene for the 38 kilodalton lipoglycoprotein, but the results demonstrating actually protection with this tool, which I'm sure they have in mind, has not been reported yet. This is again a very recent study from a Chinese laboratory, and I think I feel enthusiastic about this prospect. So finally, when we come back to address the question which Pere Joan pointed out, I would like to say, yes, we can eradicate tuberculosis if we keep in mind that socioeconomic conditions are important, that the early diagnosis of infectious cases leading to a break in transmission of the infection is improved, that we could make the chemotherapy more effective in particularly in endemic countries where it is failing because of the shortcomings both of the patient and the health service side. And finally, discover an effective prophylactic vaccine. Thank you very much.